to this special meeting with Dr. David Blodgett of the Southwest Utah Health Department, sponsored by the Washington County Republican Women of Utah. My name is Kristen Clark, and I am the president of the Washington County Republican Women. In light of the events yesterday, before I begin our broadcast, I feel like I must remind everyone who can hear my voice that one of the pillars of functional and lasting democracy is an informed electorate. American citizens do not just deserve to know the truth, they have a duty to seek out and find the facts. Knowing this, we, the Washington County Republican Women, commit and recommit to you today that we will always provide accurate, reliable, and responsible information, and we will be transparent in the sources that we have reviewed and chosen to share with you. This way you can know that all of the information you get from us is information you can trust. If you are already a member of the Washington County Republican Women, please remember to renew your membership today by visiting www.washingtoncountyrepublicanwomen.com. If you are not a member and would like to join, please stay tuned after our keynote speaker to hear how you can join us in this work. Now, in light of our commitment to correct and truthful information, we are thrilled to have Dr. Blodgett with us today. He has been an expert in public health and infectious disease since long before the COVID-19 pandemic swept the globe. And he has been working tirelessly to keep our communities healthy and safe for many years.
Hang on, sorry, people are saying they can't hear you. I just fixed volume, so let's see. Ask if they can hear you.
Can you hear me now? We're waiting for some comments from viewers.
I think it should work now.
Give me a thumbs up if I should begin again. You can't hear it?
You can hear it now, it's just
Sorry. Did you say yes?
it's really quiet. You can
It's
hear
really
it.
quiet? Okay. Should I begin again?
Okay, someone up there is a bit clear. So just tell them sorry. Yeah.
I am so sorry. I hope you can all hear us now. We will just go ahead and begin again. Okay. Hello and welcome to this special meeting with the Washington County Republican Women and Dr. David Blodgett, our special guest. My name is Kristen Clark, and I am the president of the Washington County Republican Women. In light of the events that happened yesterday, and before we begin our program, I would like to remind everyone who can hear me that an informed electorate is one of the pillars of a functioning and lasting democracy. American citizens do not just deserve to know the truth, they have a duty to seek out and find the facts. Knowing this, we, the Washington County Republican Women, commit and recommit to you today that we will always provide you with accurate, reliable, and responsible information, and we will always be transparent about our carefully reviewed sources. We also commit to you that we will be and always will remain peaceful and law-abiding citizens. If you are already a member of the Washington County Republican Women, remember to renew your membership today for 2021 by visiting www.washingtoncountyrepublicanwomen.com. If you are not yet a member but would like to join us, we welcome you. Please stay tuned after our keynote speaker and we will explain how you can join our group. Now, Dr. Blodgett with us today. Dr. Blodgett has been an expert in infectious disease and in public health for years before the COVID-19 pandemic swept the globe. We are so excited to have him with us. We will begin our program today with Yvonne Wall, who will open with a word of prayer. Following Yvonne, we will hear from Carol Bracken, who will share with us an Americanism and the Pledge of Allegiance. And then we will be excited to hear from Cheryl Snow, our moderator, who will introduce us to Dr. Blodgett. Thank you. Yvonne?
Our dear Heavenly Father, we gather together this beautiful winter's day in gratitude for our many, many blessings. How grateful we are to live in this beautiful area of the world. And how grateful we are to live among such good people who love Thee, who love our country, and who love one another. We are truly grateful for the spirit of Dixie that has passed along to us from our pioneer forefathers. Heavenly Father, we're so very grateful to live in this, the United States of America. We are indeed grateful for our inspired Constitution and thankful for law-abiding, honest-in-heart men and women throughout this country who are striving to protect and maintain our freedoms. We gather this day in an effort to learn how we can effectively live in our community with the COVID pandemic and how we can address our concerns to be healthy and to be protected. We are grateful to Dr. Blodgett for taking the time to address this issue and pray for him and all efforts being made by our medical community. We are indeed grateful for those in the health community who have been unselfishly serving at the aid of so many who have fallen ill. We pray for their protection and we pray for their personal needs. We pray for those who have lost loved ones, that they may be comforted. We pray for those who are currently ill, that they may be blessed to recover. We pray for our elderly, especially those who are feeling alone and who are grieving. Please soften their trials, strengthen their faith that they may feel of thy deep love for them. We pray for our youth who are attending school and the educators that are teaching them. Bless them to be strong and resilient at this time. We are indeed grateful for our abundant blessings and ask that thou will forgive us of our faults and weaknesses and strengthen us as we move forward. We love thee. May we always remember who we are, thy sons and daughters. May we live our lives in such a way that we can merit the blessings that we need and ask for this day and always in the name of Jesus Christ. Amen. Amen.
We've all been through a lot, but one thing we can be grateful for is that we live in the great state of Utah, and we have some good things happening here. On Monday, January 4th, 2021, a historic moment took place as Utah's 18th Governor, Spencer Cox, was sworn in. It was the first inauguration to be held outside of Salt Lake City. Yay! It was held right here in Washington County at Tuacahn. January 4th is also significant in that it also marks the 125th anniversary of Utah becoming a state. Statehood was not easy to come by, and it was a much celebrated event. During his inauguration speech, Governor Cox said, "At times our hands may hang down and our hearts may fail us. But even when we feel tired, we must never give up. In Utah, we never give up. It is our turn to write the next chapter of Utah's history and prove," said Governor Cox, "that yes, indeed, our greatest days lie ahead." Please join me in the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation under God, indivisible, with liberty and justice for all. Thank you.
We are very excited to have Dr. David Blodgett join us today for a topic that is on a lot of our minds right now. David Blodgett graduated from SUU in 1993 with a BS in zoology chemistry, and then the University of Utah Medical School in 1999. Dr. Blodgett completed clinical residency training at Bassett Hospital in Cooperstown, New York, a Columbia University affiliate, and the preventative medicine residency at the Johns Hopkins School of Public Health, where he was the chief resident. After residency, he worked at the Johns Hopkins Center for Public Health Preparedness and at the Anne Arundel County Department of Health over their emergency preparedness and chronic disease prevention divisions. He is currently the health officer for the Southwest Utah Public Health Department, overseeing the health of 225,000 people in the 5-county area, a position he has held since 2005. Dr. David Blodgett.
Well, it's really a pleasure to be here, and thank you for the kind words of introduction. But I do want people to feel free to ask questions and to be engaged in the conversation here. And I think this is something that we're all interested in, obviously, but sometimes don't know where to go to for sources. The last count I saw placed it at 4.3 billion media articles have been created about COVID. And so everybody is a COVID expert, and they always tell me about what they're an expert about whenever we get together. And so I appreciate that everybody has had a long and intimate experience with COVID and what that means in their life. And sometimes we think of disease only from the aspect of disease, but really, I think COVID reminds us that the whole spectrum of an impact of disease cuts across all areas: politics, economics, how we interact with our families. And so I think in looking at the questions, that you're hinting at some of those things that we can talk about. So I don't know how to know which slide you're on to make sure we're on the right one, but maybe if I slide them this way or something.
Yeah, that's great.
So I decided to pull some summary data just so I could give you a picture of where we are with COVID in our area and some thoughts that I have, but then I wanted to get to your questions as well. So here is the curve of the COVID vaccine, or the COVID disease. COVID-19 is actually the name of the disease, and SARS-CoV-2 is the name of the bug. Sometimes they do that just to make it extra complicated. So these are the cases of SARS-CoV-2 infection that have been identified in the state of Utah from the beginning of the pandemic. And I think it's actually pretty telling. So we peaked in our latest big surge of cases in November, about November 20th. You see how the yellow is a plateau and the blue is decrease, and orange is increasing cases. So it came down off of that peak. There was a little bit of a resurgence over Thanksgiving, and then it dropped dramatically headed into the holidays. Now you notice what's happened as a result of the holidays. So we're currently seeing a little bit of an increase in cases, but you can tell that those cases aren't very well smoothed out, right? So there were a few days there where there were almost no cases, and then a few where there was extra high. And that's part of the difficulty we deal with when we try and talk about, well, where are we in trends, is the cases are not consistently reported from the state and from us. And so I would actually say that looks like we're down off the peak about 25%. So we'll watch it as school starts and things progress, but I'm just glad we're not in that first part of the curve where it's going up and doubling about every other day or so. So this slide shows a statistic that you might hear in the news a lot, and I thought we might talk just a second about it. This shows the percent positivity. So of the people that get tested, how many of them end up being positive for the disease? And a lot of times in the news, they act like, well, that's the the most defining characteristic of it all. And if that's the case, then we're in big trouble, because now we have a higher percent positivity than we've ever had. Almost 30% of all the cases, or 34% of all the people that get tested are positive. That would be true if we had some way to test a uniform number of people every day, right? So if we could go down, pull 1,000 people randomly and test them, then the percent positivity would mean something. It doesn't mean something when you only test people that want to be tested, right? And so we're all getting better at saying, you know what, I think I might have COVID or might not have COVID. And so people don't go get tested that don't have COVID, or don't have at least symptoms that look a lot like COVID. And so I think what this shows us is we're getting better at getting tested when we actually have COVID, and not getting tested when we don't have COVID. And so don't let that percent positivity number fool you into thinking that it's something that it's not. Okay, here is a different number. You might have heard it in the news, called RT, the rate of reproduction of a disease. And so that gives us a little bit of an indicator of how fast it's spreading. And so that's this orange line that goes across the number of cases in blue. The RT, or the reproduction level, has been actually really very low going through into the holidays, but now has jumped back up. So that's more of an indicator that we're seeing more spread in the community than anything that we've got there. So it is still a time to be a little bit aware of the disease. There's perhaps more of it in the community than there's ever been, but also there is much light at the end of the tunnel ahead of us, and that's what we need to talk about. So there's two statistics that the governor uses to decide which level of category we're in, whether we have to wear masks, what the school activities look like. The first is on the left here, and that's the cases per 100,000 population that have accumulated over the 7-day period. So that's the blue line that you see there. If it drops down below 325, then you're in a moderate risk category. If you drop down in below 150, then you're in a low risk category. And so the fact that we're still in that kind of 500 range as a state gives us one check on the 3 checks for whether or not we can take masks off. So watch that statistic if you can. The second statistic is on the right there, and that's that percent positivity we talked about. They want that to drop all the way back down to less than 13% from 33. So you noted my concerns about what percent positivity means, and so we may never not have a red check against this for this statistic as long as we speak. The last statistic is ICU utilization. We'll talk about that here in a second. But this is the overall hospitalization rate for the state. So you can see that peaked right at that kind of mid-November, right before Thanksgiving period as well, and has dropped off a little bit since then. I'm trying not to bore you with statistics, but give you a nice picture of where we are. We know a lot about who gets this disease and who is in the hospital and things like this. So this is the curve. This is the numbers for who has been diagnosed with COVID. And so I put it in here visually. You can see the number one group that has had COVID is in that 25 to 44 age range. Let me just put a little bit of a disclaimer here. These are the people that we know have had the disease because they got tested. The question has always been, how many people don't get tested? How many have the disease? How many are asymptomatic, and those kinds of things. CDC came out and did a test in Utah where they said, you know what, we think that number is 11. So if 11 people have had COVID for every one that we know about. The University of Utah did that same study, and they said, no, we think it's more like 3 or 4. So somewhere in that 3 range to 11 range is how many people have had COVID for everyone we identified as a case. So that skews all these numbers, right? And you just got to keep that in mind. But here's the curve of the ages of those that we know about. And then putting that in a school context, because we've talked a lot about schools, you can see that the cases have splayed very much towards that college age group. So you look at that purple line on the top, that's about 10% of the college age population has been identified as a case. And if you were to 10 times that out, right, that's 100% of the population. So I don't know, that's somewhere in that range. I'm not sure what it is. Yeah, the next line down, the kind of aqua blue is high school. But then you see by the time you get into the middle school and the elementary school age kids, we just haven't seen very many cases there at all. And so that's been able to dictate some of the policies we've had in schools and things like that. Here's the curve for hospitalizations. And so you can see still very high rate, but those have plateaued and started to come down just a little bit. This is the curve that I think means something. The blue line here is the percent of ICU beds that have COVID patients in it. That's right at about 30%. So 30% of all the hospital beds in the state have a COVID patient in it, versus that green line, which is the number of ICU beds that are occupied for any reason. So COVID contributes to the overall percentage of people in the ICU, but every year the ICU beds fill up, particularly this time of year. Here's another way to demonstrate that. The light blue is people that are in the ICU but not from COVID, and the dark blue is the number in the ICU from COVID. And here is those that are in the rest of the hospitals. So the dark blue again is COVID. About 10% of the hospital beds statewide are filled with COVID patients. The light blue is other people in the hospital for other reasons, and the gray is empty beds. So as we track hospital capacity and worry about that, we have lots of data to kind of support the program. This, I think, is a very encouraging graph. And maybe I'll stop with all the graphs because you'll just get mad at me. But the blue line, or I'm sorry, the red line, colorblind here. So you can see it starts off in the 15 to 20% range, and now is dropped all the way down to 2%. That's the percentage of cases that we identify that end up in the hospital. So hospitalization rate per 100 has dropped dramatically. Partly we're getting better at deciding who goes in the hospital and who gets treated, and partly it is we're getting better at identifying cases. But it's not that we're having more cases, we're identifying more cases. And so, but that dropping of the hospitalization rate down to 2% is actually a remarkable development. So the light pink, those are the cases that we've been talking about, that peak and then coming back down. The dark pink at the bottom is those in the hospital, but it's that red line and how many get hospitalized out of 100 cases. I think it's really important. So here's the data that means the most to us. 26% of those over 85 that are identified as having COVID end up in the hospital, and 17% of those 65 to 84. That is a significant statistic, right? Those are the people that we're trying to protect in the overall quest with what we're doing here, and that guides vaccine policy and everything else that we're doing. But those are the people that we're most worried about, because 25% ending up in the hospital. The other really alarming statistic is in that 85 and older crowd, 25% up in the hospital, and almost 90% of those that go in the hospital die. And so much, much more fatal. And I'll show you the fatality statistics here in a second. But so here is the mortality data from a percentages as well. So of the deaths that have been experienced in the state of Utah, 0.9%, if you remember from our curve, were over 85. There were cases, but 26% of the fatalities are in that age range. So it's about, it's orders of magnitude more fatal the older that you get. And 51% of the deaths have been in that 65 to 84 age range. So 80+% of those that have died have been over the age of 60. And then when you add underlying medical conditions, that's what this line is, 90%, 92, 94, depending on which date you look at, have been in a high-risk category, either from age or from having an underlying medical condition. Heart disease, high blood pressure, obesity is a big one. So we really know who it is that needs to be most protected, and we need to. We've had that message consistently out there. I hope that's not the first time you heard the message, but it's nice to see where that comes from. One thing that is really a nice light at the end of the tunnel, you look at this percent mortality category overall in Utah of the cases we have identified. So that's always the disclaimer. 0.5% of those that have had COVID have died, right? And so that's 99.5 don't die out of every 100 to get it, but 0.5 have. That's lower than anywhere else in the nation. It's a very low statistic. It's very comparable. By the time you figure, well, we just haven't looked at all the cases, it's probably very comparable to where the flu comes out every year as well. And there is a line. So this line, you try and get a line to help people understand risk, but the line is, are you more likely to die in an automobile accident or from COVID, right? And so you can actually draw a line down that graph, and the line hits at 62 years of age. So you're more likely to die in a car accident if you're under 62 years of age than from COVID. And then above 62, you're more likely to die from COVID than anything. So hopefully that helps put it in a little context for you. So I put in a few questions here, but maybe I can just finish up with a little bit of a discussion about the disease itself and how that relates to vaccine, and then we'll do all of your questions. So am I okay? Have I bored anybody yet? We're fine. Okay. So this is a picture of what coronavirus looks like. They call it coronavirus because it looks like a crown when you look at it under an electron microscope, because all of these yellow components you see on the screen there are called spike proteins. And the spike protein is what allows it to identify, they're called the ACE2 receptors, which is also tied into hypertension. So some of us might be on ACE2 receptor inhibitors for hypertension. All of it fits together. Anyway, those spike proteins glom onto the ACE2 receptors. This is maybe more than you wanted to know. It opens up the cell and it dumps its content in there, and it takes over the machinery of your cell to start producing millions and millions and millions of copies of the virus. And so there's this arms race going on inside your body. The virus is trying to reproduce as many copies as it can to try and get out and go on to the next person, while you're doing your best to figure out how to defeat it and kill it. And that happens all at the same time, right? So this spike protein looks pretty simple in this diagram, but this is what the spike protein looks like under an electron, as a 3D rendering of what those proteins look like. So why would I show you that hideous mess? Because I want to talk a little bit about with the current vaccines that are available. They're called mRNA vaccines, and I want to put it in context for all this hubbub that's in the news about mutations and are we all going to die because of mutations and stuff like that. So I'm going to come back to this slide, but kind of put it in your mind. It looks a little bit like, what does that look like? Last time I made breakfast or something. So the vaccine then delivers an mRNA component into cells that is targeted towards binding onto these spike proteins. So what happens is, if you produce antibodies and those antibodies grab onto that spike protein, it no longer can bind onto your receptors and then make it into your cells. It stops the process of being able to do that. And so the unique technology that's come out with these new vaccines is, rather than just present the whole virus or an inactivated virus or something that may or may not teach your body how to respond, it puts a very specific section of what's called mRNA, which the body uses to then transcribe into proteins. So, and it has a limited life because it clips off a little bit of that mRNA every time it does it, and it's designed to be self-expiring. So it comes in, it trains your body to produce the protein, which it needs to be able to identify in order to get onto that spike protein, to stop it from invading your cells. It teaches your body how to produce that long enough to get a robust immune system, and then disappears from your system. And now you have a capacity to identify that disease and get rid of it without having to go through the process of getting sick and then developing that. So it takes about 2 weeks for that process to happen. So the beauty of vaccines is you're teaching your body how to fight off a bad disease before you have to go through that whole process. And sometimes the disease wins, sometimes you win, but you tilt those odds much more in your favor when you do it with a vaccine as opposed to me. So So that's the natural process of how the body creates an antigen to begin with, right? It takes into the body the disease that's been identified it takes into the cell a disease that's been identified. It creates that mRNA, which then is presented on the surface of the cell. You can see down here at the bottom that MHC, the major histocompatibility complex, or antigen presenting cell. That then advertises to all of your immune cells, this is the disease that we're trying to fight off. Come figure out how to fight it off. So it's actually very elegant. So the question is, well, what happens if you get mutations in this spike protein here, and that's what you're targeting with the vaccine? Is that going to make it so that the vaccine no longer works? And so that's why I wanted to show you this picture. Look how complex that is, right? You have to have a whole bunch of changes and before you impact whether or not that vaccine works. And it has to be the exact same targeted component to that. And the chances that are happening are really, really, really tiny. Now, it's not impossible, but it's not nearly as likely as the news would have you believe. So there isn't any evidence that the vaccine won't work. There isn't any evidence that the bug has changed significantly over when it first came out. It's a very stable bug, actually. It's not like the flu that changes. The spike protein for flu changes almost 100% every year. That is not the case with coronavirus. And I think, I'm not making any predictions, but it's unlikely that we will face a scenario where we've all had a vaccine that now no longer works and we have to keep getting more vaccine. But we'll watch that as we go through. That was part of the question. So, okay. Would you like me to just launch into some questions, or how do you want me to do that? Do you want to ask them to me, or do you want me to?
Let's have
We can ask them to you, or you've got them right there if you want to just select yourself.
Either good. Okay. What age groups should be vaccinated? Everyone should be vaccinated when they're eligible to be vaccinated. Children currently under 18 are not eligible to be vaccinated. The vaccine has not been studied under 18, at least the Moderna vaccine. It's 16 for the Pfizer vaccine, but about the same age range. So those studies are ongoing, and the hope is that the vaccine will be available for kids before we head back to school, so that that will help with the whole school situation. But at present, they're not eligible. Currently, we're vaccinating healthcare workers, school teachers and faculty, and first responders. We hope to get through them very soon. The governor wants it to be faster than it is now, and be able to start into over 75 age range by the beginning of February. So we're moving right along. In the last week, we gave almost 30,000 vaccinations as a state system. Let's see, are there any pre-existing conditions that would preclude somebody from getting vaccinated? The only precaution we have on the vaccine is if you have had an anaphylactic response to a previous vaccination, then you ought to talk about that with your doctor before you get vaccinated, and do it in a place where there is appropriate response available. That there have been 3 examples out of probably 30 million doses administered where there was an anaphylactic response to the vaccine. So that is very, very rare, but that's why we ask you to sit there for 15 minutes after you get vaccinated, and we'll watch you.
We had a question come from online. Can you read it?
If most of the deaths are 65 and over, why are teachers in line ahead of this group? I'm only taking easy questions today. There are just certain groups that made the case to the governor that they should be ahead of other groups. That's the only way I can say that. So, okay. Will the vaccine work on the new variants? Okay, I think we answered that question. How long before the vaccine gets to the general public? So, like I said, I'm hoping that we start into the over age 75 range beginning February, maybe as soon as 2 weeks from now. I hope that's the case. Do we have vaccines available but have not been administered yet? So I know there's been a lot of press about this. It's part of it is the way the vaccine's been distributed. So about half of the vaccine was carved off and sent to what's called the Federal Pharmacy Partnership, where pharmacies, CVS, Walgreens were given about half of the initial doses of vaccine to vaccinate people in long-term care facilities. And they have been slow in ramping up their procedures. They haven't, even in our area, done very many of those. And those are the ones you want to see get done first, right? And so there was a big push from corporate Walgreens folks to say, we want to vaccinate those people, and they were given a bunch of the vaccine, and so it hasn't been delivered very quickly by then. Another 2/3 of the vaccine, or most of the vaccine that came into the state in the initial weeks, went to the hospitals, and they were given allocations based on how many people were in the hospital, and then only about 40% of those people took the vaccine. So it looks like there's a bunch of vaccines sitting there, and they're working on how do we give that to other people now that our people have decided not to do it. We got our first shipments about a week ago, and we've already given all of ours out. So it's just a matter of there's so many players that some have been able to get it out better than others. Local health departments, that's what we do, right? You've all seen our shootouts that we do every year. We've been practicing this for 15 years. We know how to vaccinate. So any vaccine that comes to us, we get it out within a few days. We try and make it a nice experience to come through too. So we've got a scheduling app now where you can get scheduled, and so if it almost feels like you're the only person coming through, but that's just because we've got it all scheduled out. So I hope it's been nice for everybody to do that. What's the schedule for vaccination? It is a 2-shot series presently with the Moderna products. So you get a shot and then you get another shot 28 days later. That is 95% effective. So these vaccines are perhaps the most studied vaccines in the history of vaccines. 60,000 people in each research arm in the Moderna vaccine, 30,000 Pfizer vaccines. And so the capacity to really identify the safety profile as well as the effectiveness profile has been very, very high. It is a rapid development process where they kind of stacked some of the steps on top of each other, but they still did all of the steps, and it's a very, very safe vaccine. How long after you vaccinate are you actually immune? The answer to that is 2 weeks. So it takes 2 weeks for immunity to build up, and they're not considering you immune after your first dose, only after your second dose, right? So that will be when you don't have to quarantine or isolate or any of that stuff anymore. But so far, still have to wear a mask. The CDC's guidance is that wear a mask. We'll see how compliant people are with that. We'll see. Let's see what groups are currently scheduled to receive vaccine. I think we talked about that. What is the difference between the Moderna and Pfizer vaccines? Interestingly enough, both the Moderna and Pfizer vaccines are mRNA vaccines like we talked about in the pictures. So they're very, very similar. They just have a little bit different mRNA sequence, which targets a little bit different part of that spike protein than was on there. And so they are very, very similar vaccines. The Pfizer vaccine requires storage at minus 70 degrees Celsius, though. And so that is a much more difficult vaccine to deal with. We have so far been lucky enough to only deal with the Moderna vaccine for that reason. But that's the only difference. If you have the ability to store it, it's virtually the same vaccine. Will those 65 and older go to a pharmacy or their doctor? How will they be notified? What is the health department scheduling app called? So if you go to our website and you click on the banner that is the COVID banner and open up to our COVID page, there's a big green button that says information for vaccinations. If you click on that, it will open up and show you all of the clinics that we have available. So there's a Washington County tab, and then when you click on Washington County, it will give you all the slots that are available coming up. So there's the groups that are available to get vaccinated, and when it pops up and says we're now vaccinating everybody over 65, that is your cue that you can either come to the health department by scheduling in the app, or I suspect by the time we get into more of the general population that it will be available at CVS and Walgreens and all of those places to walk in and get. I hope it is. But in all of this, the limiting factor is the amount of vaccine that's available, right? I mean, even just the over 85 category, there's something like 10,000 people over 85 in our area. And our allocation so far has been 1,200 doses a week. So that's 8 weeks, right, just to get through that age range. So as the vaccine becomes more and more available, and then you got to remember we got to go back and revaccinate everybody we've already vaccinated after 4 weeks. So the logistics of this are just challenging at best, but we have the capacity to deliver 10,000 shots a day if we have the vaccine with our big shootouts. So it's just a matter of getting the vaccine in our hands and then getting them into your arms. So be a little patient with us, but I think you'll find the process really works well. And we will keep that website updated with those current groups that are available on a daily basis or more. So that answers that question. Let me see. If you have a fever after vaccination, are you contagious? No, this vaccine does not include any live virus or any capacity to have the virus at all. All it is that little mRNA sequence. So there is a fairly robust immune response to this vaccine. People feel achy for a day after. One of my employees even reported a little bit of nausea, a little bit of kind of ache in that arm, but generally it's gone away after a day or a day and a half. So maybe a little Tylenol to go along with that. So it's possible you could have just a little bit of fever with that, but that is not the disease. It's not infectious. It has nothing to do with the disease. Are we behind in administering vaccines? I think we talked about that. If you already had COVID, should you still get vaccinated? How long does immunity last? Both from having it and from being vaccinated. That's a great question. So if you've already had COVID, the current recommendation is that you still get vaccinated when you have an opportunity to. Part of the reason for that is that they know that with vaccination, the immunity lasts for a much longer period of time. It stimulates a T cell immune response instead of just an antibody response, which is what you're looking for. Part of the reason for that is it's hard to know if people really did get it or not, or whether they just thought they got it, some of that. But there's also this very small percentage of people that have been reinfected. And so the natural course of most diseases is you get infected and then you're immune to the effects of the disease, but you're not immune to getting infected and then transmitting it, right? And the percentage of that happens with COVID isn't really very well studied, but it's thought to be fairly high since there's 4 naturally circulating coronaviruses that hit every year. So about 30% of the common cold that hits every cold and flu season is the coronavirus. And we get them over and over and over. And the thought is that's not really bad if it's the common cold, but if there's a certain percentage of the population that dies doing that, then that doesn't really help. So that's another reason why the vaccine's recommended. I don't know. So if you're currently sick with COVID, you're not supposed to get vaccinated. The question is, how long do you wait after you've been sick? Currently the CDC says if you've filled your 10-day isolation sentence, if you want to call it that, you can go ahead and get vaccinated if you don't have any symptoms. I don't know. It probably doesn't hurt to wait a little while. You've got some immunity there, and you could let somebody else have a vaccine. I don't know if there's any factors like that should be taken into account. It's not part of the CDC recommendations. So. But I would recommend that everybody get it when they're eligible. Okay, let's see. Now, I have one more set of questions. How am I doing on time?
You're good.
Are we good?
Yeah,
all right.
10 minutes.
Tell me when I'm ready to
You're
be
good.
done, because I can talk all day. Let's see. What are the chances of getting COVID even if you are vaccinated? Currently, that number is less than 5%. So about 95% effectiveness with the vaccine. It's one of the best vaccines that's ever been produced. And even in those that did get infected after they had the vaccine, none of them had severe disease. So we run into this kind of distinguishing factor when we talk about vaccines that I don't think people really think about. And that is with the flu shot, we always say, it's only about 70-75% effective. But it's almost 100% effective in preventing severe disease, right? So people get vaccinated, They might end up with the flu, but they don't end up in the hospital, right? And that's there's a difference between getting infected and getting severe disease, and we don't always tease that out. But with the COVID vaccine, it's 95% effective in not even getting sick, but then none of those that got sick ended up in the hospital either. So I think that's a kind of an important thing to point out. So that's a good question. Is the new, more contagious strain of COVID expected to hit southern Utah? So I love how the press uses terms like more contagious, so everybody wants to run and hide, and it just really drives me crazy. So are there mutations to the COVID constantly, like we talked about? Absolutely. Is this new one more contagious? I don't know. I don't think the studies have really been done. What does that mean? Probably not that much, right? It's the same steps to keep it away and things like that. Will it hit southern Utah eventually? Probably, just like everything else, it circulates through. And what happens is a new strain comes out, it becomes the dominant strain. It looks an awful lot like the old strain because it is the old strain, just with a few extra mutations. And so I don't want everybody to think that somehow the game has changed with, there's in the British database where this one came from, there's 23 million variants of COVID, right? I mean, almost every time you replicate this virus, there's a new version of that strain. It just doesn't mean it's going to be significant in the overall course of the disease. So you keep it peeled. If they come out, if they do the studies and say, well, it really impacts whether or not the vaccine works, how it gloms onto that spike protein, then we'll be worried. But so far, the evidence is it hasn't changed that at all. So that's good. Am I going too fast, too slow?
No,
Sorry. Give me that thumbs up. Surges of COVID-19 were predicted after the holiday season. So we showed you those numbers, a little bit of an increase there. So just be aware. I think actually, as we see those clear, we're going to see a big drop off. I think we've hit a lot of people in the population. So we'll see. How do COVID-19 cases in healthcare workers compare it to positive rates in the rest of the population and that are not healthcare workers? Interestingly enough, there hasn't been a higher rate in healthcare workers than just in the general population. That's because we've been very good at making sure they have PPE and gowning up and all that stuff. The number one place to get COVID in the healthcare setting? In the break room. Very good. We've got a smart person over here. So they gown up, they're in the moon suit, and they take care of their patients, and then they take off their mask and everything and go and eat lunch, and then they get it from each other. So their rates look very similar to the rest of the population. How likely is it a person who is not yet exhibiting any symptoms of the virus could spread it to others? That has been one of the hot topics and questions of this virus from the beginning. Most data and most studies that I have seen say it's about 15%. About 15% of spread happens from somebody that does not have symptoms. Most of the rest of the spread is within 2 days before they start to show symptoms, or they're starting to show mild symptoms, to about 2 or 3 days after they show symptoms, with about 80% of the spread happening in that day or two after they start to show symptoms. And when you think about it, that makes sense, right? Because you're starting to cough, you're starting to do things that expel virus. That makes it much more spread. And you think when you're asymptomatic, you can do it just by talking and things, but it really is. This really is a disease of close contact, right? Within 6 feet for more than 15 minutes, really face-to-face kinds of things, and so it's not a disease you pick up, walking down the aisle at Walmart. It's a disease you pick up with your family, right? And one of my favorite stories is there was a doctor giving me a hard time that we weren't throwing everybody in jail for not wearing masks, and then he showed up with COVID on the list. So I called him to give him a hard time. I said, so what happened? He said, well, my daughter came home. And so it's the same story. It's a close contact. When can we unmask? That's a question you'll have to ask the governor, because I haven't ever had a mask order. So I really hope that the vaccine changes the whole discussion and we can start to take masks off. how we achieve herd immunity, about 60 to 70% immunization rates would do that. I think we'll say once you have a chance to get vaccine, that's good enough. But I don't know. I'm not the governor, and he's made all the rules for this stuff. We have a new governor. We'll see where he goes, but I think it's going to look a lot the same as the old governor. Let's see. Asymptomatic spread we talked about. Reasoning. Behind the hospital administration versus medical staff reporting of what's going on in the hospital. I showed you the numbers. I think there's an effort to try and create an idea that, this is a community effort and we want to all do what we can to stop the spread. And I think sometimes I think the message has been more dramatic than it needed to be to get the same message across. Does that make sense? And I think this is a disease you want to not get because you don't want to get it, or because you don't want to spread it to somebody that's really vulnerable. And I think that needs to largely be something we do because we want to do it. I don't think you can force people to do anything. And I hope that that's the messaging that we've had out there. It's consistent, right? There's a whole toolbox, and hopefully we're all using that in our lives. We're getting close.
We've got about 4 minutes.
Do you get any pushback from the state for not being as doom and gloom and restrictive as they are? I don't like that question. So you need to know that I'm the last physician health officer in the state. Used to be that all 13 health departments had a physician health officer, and that gave us a lot of ability to talk things through, and we had really nice plans, and we had a cohesive group. But now I'm the last one, right? And so I often look like the rebel because I insist on thinking for myself, and I say something different than the state does sometimes. That gets me in trouble. So do I get in trouble sometimes? Yeah. I try not to. I really try and behave myself. But sometimes, I don't consider myself bound to think the way everybody else does. I went to school for a long time too, right? So, so that's a kind question. Any other summary questions before we get done, or maybe we're close to the end? I don't want to blow your calendar. Oh, we've got 7 minutes. Maybe we can answer another question or two. So, are the flu stats counted fiscally or annually? Are COVID stats done the same way, and what difficulties arise in comparison based on the difference in stats? So somebody's been doing their homework. I always appreciate that. Yes, we track flu on an August to August basis. So it's not true fiscal, but it is yearly. So when you look at flu statistics, it is a yearly statistic. And yes, we have not done that with coronavirus. We have looped over into a new seasonal year. And because this is a seasonal bug, you're right, that's not fair, right? And so we're trying to compare apples and oranges in a lot of ways. I think you can speculate on why that would be done, but I think you give it another year and we'll be back to a seasonal comparison of this with everything else. And likely this will look a lot like every other influenza-like illness just after it's had a chance to go through the population. So usually the statistics in epidemiology are that 80% of a population will get a disease within 5 years after its introduction into the population, no matter what you do. Right? So, unless the only thing that really intervenes in there to lessen that number is if you expose somebody artificially, right? So you still have 80% exposed, but you've done it artificially by sticking a needle in their arm and giving a vaccine. Otherwise, that's the only way to stop it from getting to 80% of the people in the population within 5 years. That's just the way it happens, no matter what the disease is. So, for travel purposes, how long is a vaccine certificate good? Is there a vaccination certificate out there? I don't know if that's a real thing. Yeah, you do, and it tells you to come back. And I don't know if we're going to have a situation where they'll say, you can't fly if you don't have the card or not. I hope we don't do that, but I'm guessing we might get into that situation. And I just don't have an answer for how long they would say that would be good. The CDC now gives you an exemption on everything if you've had the disease for 90 days. So if you've been sick, then all this testing to go to school and all that stuff, you're exempt for 90 days. I think it's going to be much longer than that. Hopefully it's permanent, but I just don't, until we get some more time, I just don't know what the answer to that question is. I don't think anybody does. But there was talk about a kind of a certificate if you had an immunoglobulin test, antibody testing, and that kind of flopped too. I think it's just really hard to standardize and track something like that. So I don't know if that would be. What is to be done, if anything, about fraudulent information and statistics regarding COVID and vaccines? Yeah, I don't know. If you could figure out how to stop Facebook, then you're doing better than I am. And I actually don't know that it's the false information that really disturbs me as much as the uncivility of some of the discussion, right? I mean, it's really, you're an idiot if you don't believe the way I do, and I'm right and you're wrong, and everybody's evil that doesn't do it the way I think they should. I don't know how we restore some civility to some of that dialogue, but my perception in all this is people are really trying hard, right? And I think most people want to do the right thing, and nobody's really out there trying to ruin everybody else's life. It's just that we're operating in an environment of uncertainty creates some of those kinds of things. And so that would be my plea is, yes, look at credible sources. We try and be as very accurate as we possibly can be on our website, and try and be as completely open and transparent as we can be about everything we're trying to accomplish. But we still, in the end, just have to be nicer to each other. I think that's possible. I see one more question coming down the pike over there. So I'm ready to. Man, this is going to be a hard one. I want to take an easy question too. Okay. Is the vaccine safe for immunocompromised people? Short answer, yes. There hasn't been any evidence that people with any immunocompromise should not be vaccinated. When do you expect it to be available for that group? I really think where it's going to go after we finish up with the first responders and the current risk groups that we're vaccinating is we're going to go down the list for age groups, right? We'll start at either 85 or 75 and older, then we'll drop down by 10 years and we'll just go through the population that way. So generally those immune compromising situations are more likely to be when you're older, and so those things line up a little bit, and so we'll be able to get to those as we get to them. But I think that's going to be the plan once we hit February. Is we'll start down the age ranges, and I don't think it's unreasonable to expect that we could be doing mostly anybody that wants to get vaccinated by April, May. That's my hope. So, not July like they were saying initially. I think we're moving much more quickly through those groups than we thought we would, so, which is good news, right? Well, this is a fabulous group, and it's been a pleasure for me to be here. Thank you for the opportunities.
Thank you.
Well, thank you, Dr. Blodgett, for joining us and sharing your expertise with us. And thank you to all of our viewers at home for spending an hour with us today. We hope that you feel more qualified to make wise decisions about COVID-19 and the COVID-19 vaccine, and that this will help you. Remember, the Washington County Republican Women is an organization that welcomes members, both old and new. We're committed to providing accurate information for you. If you would like to join us or renew your membership, you can do that by going to www.washingtoncountyrepublicanwomen.com. A basic new membership is $45 and a renewal is $35, or you can also choose to donate more to our club by joining as a GEM member. We welcome women as members, and we also welcome men as associate members to our club. So one more time, thank you for joining us, and we'll see you soon.